I'm Dr. Sarja. I hope all of you are safe. We are back again with Facebook Live. I am from the Ranchi branch. Today, I will be talking about ART treatments, basic and advanced. I want to start by saying, which is very, very important for all patients to know, why we have so many discussions about what treatment a patient should go for, what is suitable for them, and this because is that fertility is not a life threatening condition. Fertility, it is very, very important for patients to understand this. So we have sometimes patients telling us ki ma'am, you decide, aap decide kariye kya best hai. No, there is a reason why a fertility specialist should not decide what treatment is best for the patient, because fertility diseases are not life threatening. Nobody is going to die if they don't have a child, but they are very, very emotionally draining. There are a lot of finances involved. There is a lot of time involved, a lot of patience involved. So it's very important for patients to understand why we are, as a good clinician, I feel it's a job to tell them that this is what is best for you. This is what we feel is going to be the best for you. Obviously, we cannot leave the decision entirely to the patient that this is what we have. Now you decide. We have to be the guiding force. We have to help the patient decide as to what treatment they should go for, but eventually the decision has to be from the patient. There are various different forms of ART treatments, right from basic ART treatments to advanced ART treatments. I'll put another subcategory to it called very advanced, because I want to talk about that separately and I don't want all of you to get confused. तो मैं इन सबको अलग अलग तरीकों से explain करूंगी for your better understanding. I will start with basic ART treatment, which involves ovulation induction, timed intercourse, ovulation induction, and IUI. These are very, very basic ART. Ideally, timed intercourse does not come into ART because there's nothing much that we are doing. We are just making sure that the patient ovulates. But IUI, technically, by the book, is the first form of ART treatment. What we do in IUI and what we do in TI, timed intercourse, is almost the same, except that the steps which are common in these two are: we give ovulation induction drugs. Once the egg is formed, once the egg is of a certain size, we give an injection for the patient to ovulate. And when the patient ovulates, we tell them, okay, now you've ovulated. Now this is the right time for you to, for both the partners to meet. And if it is an IUI, we check that the patient is ovulated, keep a gap of 1 or 2 days where the patients are having intercourse regularly, so that there's a cover, there's a bracket. And then we call them to the center and we put the sperms, the artificially prepared sperms, filtered sperms with better motility. We prepare them and we put them into the uterine cavity. What happens here is, this is a very, very, why we call it a basic treatment, because all we can do is make sure that the patient is ovulated and that we have ensured that the sperms goes into the uterine cavity. And beyond this, we cannot do much. So the success rate of these treatments also varies. The maximum, it goes from 15 to 20%. By that I mean, if we treat around 100 people with this treatment form in one cycle, around 15 to 20 of them will conceive. This is very, very important for the patients to understand. Why? Because when they're choosing to go for a treatment, it's every month that is counted. We have to make sure that the patient is aware why we are asking them to go for basic treatments, why we are asking them to go for advanced treatments. The basic discrimination as to when we put a patient into basic, that they can go for basic treatments or they should directly move to advanced, is age, the most important criteria. We have to make sure that we have age in hand. We have to make sure that the ovarian reserve tests are good. By that I mean the egg reserve of the female is good. We have to ensure that the male factor is not very, very prevalent. Obviously, we cannot do a basic ART treatment when the male sperm count is less than 10 million. So these are the three most important things. Another very important thing which we should ensure and that we have noticed and we have taken into account is the fact that what treatments have the couple had before they've come to us. If a patient has had basic treatments, they've had ovulation induction, they've had IUIs for almost 12, 13 cycles, or maybe 2-3 years also sometimes continuously, it is not advisable for us to ask them to again try for basic treatment. We should guide the patient. We should tell them कि आपने already simple treatment try कर लिया है, even if it has not ended up in conception, even if आपके ovarian reserve test ठीक हैं and we have time in hand, हमें ये सोचना पड़ेगा कि maybe there is an advanced problem, there is a problem which we are not being able to identify, which we probably will get to know in an IVF cycle, and then they should move for IVF. So, it's very difficult. I feel this is the most important step when a patient comes in ART, is to decide as to which treatment to put the couple into. And the fact that we explain to the couple that this is the treatment that we're going for, these are the steps involved, this is the investment involved, this is going to be the time involved, this is going to be the outcome of this treatment. We have to ensure that we tell the patient that this is these treatments are very limited success rates, but because the patient has not had any treatments, they can be one of those 20 people out of 100 who will conceive in this cycle. So it's you should never say we should never say that no, you cannot go for basic treatments, or yes, you have to go for advanced. So there has to be a very thin line between these two. I'll start with basic advanced first before I go to very, very advanced. Basically, they all come in advanced ART, but for your simple understanding, for people to understand simply, I'm explaining this in two subgroups. I will talk about basic advanced IVF treatments, advanced treatments. In that, what is important is IVF and ICSI. These are the two most important advanced ART treatments. It's very simple. There's not much difference between IVF and ICSI. The process of preparing the eggs, preparing the patient for egg retrieval is the same in both. We give injections every day from the second day of the period, not every alternate day or as and when needed, how we do it in OITR, because there we look at very limited number of eggs. We should not get more than 2 eggs. It's a bad cycle if a patient gets more than that. But here we have to ensure that we produce at least 8 to 10 eggs, because the patient is paying more. So they should have at least 2 embryos, if not more, for vitrification, so that the patient has a fair chance at pregnancy. For us to get 2 eggs, we should at least, 2 embryos, we should at least aim for, I would say 8 to 10, and then we can probably, if it's a good cycle, we should get around 4 to 5 or maybe 6 embryos out of that. So here we start injections, we make sure that the patient is ready for egg retrieval, they have a good number of eggs. Post egg retrieval, we have to divide, whether we have to decide before, obviously, before we do the egg retrieval, as to what form of ART are we going to do for them. Are we doing IVF or are we doing ICSI? A lot of patients ask us what is the difference between IVF and ICSI. So the difference is, in IVF, we just leave the 2 gametes, the male and the female gamete, to meet in a dish, to meet on their own. And what we do in ICSI, it's slightly more a step ahead of IVF, in that we don't wait for the egg and the sperm to meet on their own. We take the sperm and we inject it into the egg. Here, in a way, we are ensuring that the chances of failed fertilization is lesser. But again, there is a debate which is not yet very conclusive as to whether IVF is better or ICSI is better. There are studies which say that IVF is as good as ICSI, but there are, again, it's a very clinical decision for the clinician and the embryologist to decide. If there are reasons, a history of failed fertilization or male factor, we have to do an ICSI. We cannot let that cycle go and wait for the eggs to fertilize. So that is IVF and ICSI. After doing this procedure, we wait and see that the eggs and the sperms fertilize post 24 hours, and then we culture them for 3 days or 5 days, depending on the case. Ideally, we do a day 5 transfer if we feel that a lab is good, because again, that is a step ahead. A day 3 transfer, if a patient conceives, it's the end of the story. If the patient does not conceive, our next question would be whether the embryos grew in her uterus up to day 5, or whether the problem came up after that. So if we put a day 5 embryo, which is called a blastocyst, we at least ensure that there is one more step that we have covered towards pregnancy. So that is another thing which is important. A blastocyst transfer, IVF or ICSI, these are all advanced forms of ART. When it comes to, again, here, there are many other things that we can do to improve the chances of pregnancy, like artificial hatching, using adhesive materials. These are all just adjuvants, I would say. But then we can decide as and when, as per the case, depending on how many cycles they've had in the past. Is this their first cycle? Is this required? There are a lot of things that can be done. But do we have to do it for everybody? or shall we pick and choose? And here we are assuming that, okay, these are the things we have not done, but assuming that these things should not be a problem. Because just because we have access to so many things does not mean we make the patient pay for all the possible tests or all the possible treatments that we have. It has to be a very clinically driven decision, looking at the patient profile, and for us to decide as to if I am making a patient do something, if I'm making a patient pay an extra amount or go a little more advanced in the treatment, how much is it going to improve their success rate by me doing that, by me making patient take that extra step. So these are all very, very important things, and we always ensure here at Oasis that we speak to the patient. We tell them that this is what I suggest you should do, but if you don't do this, this might happen, and if you do this, this might happen. These are the ways we can improve this. Or if there is no such thing in fertility that if you don't do it, it will not lead to a pregnancy. Like if you like, for example, in IVF, does not, just because a patient has low ovarian reserve or she has an advanced age, does not mean that she cannot become pregnant with simple treatments and she has to rush into ART. Our only reason for moving from basic to advanced is to increase her chance of pregnancy. We need just one egg and one sperm for patients to become pregnant. But the difference is how much time do we have to make that. That is the most important thing that puts us from one subgroup to another. When it comes to more advanced, as I was mentioning previously, I would want to add pre-genetic testing, pre-genetic screening, ERA, all of these things into this subcategory. Because these are not essential for everybody. Even if a patient is going for IVF, does not mean they have to go for pre-genetic testing or they have to go for ERA. There are reasons why we ask them to go for this. Like, for example, a patient has had one failed IVF cycle and this is their second time they're going for it. We have to be a little more vigilant. We have to do something better than the last cycle so that their chances are improved. There is no point just doing a very similar cycle and then ending up with the same result. What better can we do from the last cycle to improve their chances? Because with every cycle, it's very, very difficult for the couple to get up from that failure of that one cycle into another treatment mode with that changed mindset. It's very, very difficult. So we have to, at least the way we think, our aim is that one cycle should be that patient's last cycle, and we should do everything that we can to ensure that they conceive. So here, just because we have access to PGS and ERA does not mean we do it for everybody. We should advise PGS to patients if it is their first cycle only when they are of advanced maternal age. By that, I mean if the female partner is more than 35, we should definitely give them the option. It is up to them whether they want to go for it or not. A pre-genetic testing for aneuploidy will not ensure that the couple will become pregnant or she will not become pregnant. It will increase her chances of having a live birth. Why? Because after 35, the oocyte starts having DNA errors. There are DNA defects in the oocyte that is produced by a woman after the age of 35. So there is a very high risk of the embryo being abnormal. We might end up making the patient pregnant, but then she'll end up in a miscarriage. And our aim is not just to make the patient pregnant and end of the story. No, our aim is we feel that we have done the cycle, we have ensured everything only when the couple is gone home with a baby, with a healthy baby. So that should be our ultimate goal, from the patient walking into the center for fertility treatment to going out with a healthy baby. That should be the vision that we should have. So for this, above 35, the option of PGS should definitely be given to them. We should ensure and tell them that even if I get a good 8 to 10 number of eggs, if our egg reserve and all that is good, and we might create 4 to 5 embryos, if I do a pre-genetic testing, you will have a better shot at having a live pregnancy, because I will not know about the aneuploidy status of the embryo until we actually go back and test the embryos for that. So that is one thing which is very, very important. Other reasons for PGT is obviously history of repeated implantation failures, repeated IVF failures, any diseases running in the family. All these are a separate, I think we can have a separate discussion on the indications of this. The other thing that I was mentioning about, which is the most advanced when it comes to the uterus, is ERA. the endometrial receptivity array testing of the endometrium. Here, what we do is we do a genetic testing of the endometrium. And we test and we do, it's called personalized embryo transfer. Basically, here we time the embryo transfer. We ensure that the time at which we are doing the transfer is going to be the correct time for the patient to conceive, and then we do the transfer accordingly. This is again not indicated for everybody. This is only for patients who've had implantation failures in the past. By that I mean where there have been good embryos that have been transferred, good, beautiful looking, probably even PGS, pre-genetically tested embryos that have been transferred and the couple is not conceived. Then we have to think about any problems being there related to receptivity. So this is again advanced ART treatment that we have. But just because we have something from a basic OITI2 and ERA does not mean we do all of this for everybody. It is for us to meet the patient, talk to them, see their history, evaluate them. So we never make a decision on the first visit. You know, it's never that the patient has come today and I know today only what am I going to do for her. No, we have to evaluate the patient. If we feel that the tests are not relevant, कुछ tests पुराने हो गए हैं, अभी हमें लग रहा है कि ये relevant नहीं है, 2 साल 3 साल पुराने हैं, या कुछ tests ऐसे भी होते हैं जो 2-3 months में validity अपनी खो देते हैं, तो we have to evaluate, see everything. If we feel some test is not very reliable, we should ensure that we repeat it, do a good semen analysis, all of that, and then come into this. When it comes to male advanced ART treatments, there are various options like I'll start with an azoospermic male. Suppose a man does not have sperms, does not mean you ask them to go for a donor IUI. They have options of having their own genetic child. We should always evaluate what is the reason for azoospermia. Sperms क्यों नहीं मिल रहे हैं? Obstructive है, non-obstructive है? क्या reason है sperms नहीं मिलने का? And then what are the chances of getting sperms if we do aspiration? Doing a trial aspiration. At Oasis, we do a trial aspiration. If we get the sperms, we freeze them, and then we start working on the female partner. So teaser, and if a teaser also fails, sometimes if a micro teaser is required, even that can be done. We use microscope, and then directly from the better looking seminiferous tubules, we take out the sperms and use them and try and retrieve sperms there. That is another advanced technique. When it comes to miscarriages in the females, there are various things that we need to test even in the man. There might be a male factor which is causing implantation failures in a female or miscarriages in a female, which is called the DNA fragmentation of the sperm. So we have to ensure that we do a DNA testing of the sperm. ये थोड़ा और advanced एक step होता है basic semen analysis से in a man. So we need to ensure that we have done that for the man before we jump in the gun and do a treatment for them. If the DNA, the sperm is very, very DNA fragmented, we have better techniques of retrieval of the sperms. Like we have the option of doing a teaser, directly take the testicular sperm, जिसमें relatively कम DNA damage होता है compared to the sperms that we get, which is given to us by ejaculate. The second option is doing a magnetic sperm cell sorting. इसमें we have a machine जिसमें एक magnetic field होता है जिसमें हम sperms को pass करते हैं. And there are different fields in which these sperms get separated. जो apoptotic sperms होते हैं जिसमें DNA damage ज़्यादा होता है वो एक तरफ आ जाते हैं, जिसमें DNA damage कम होता है वो दूसरी. And we use the sperms which have less DNA damage. So this is another way of choosing better sperms for ICSI or IVF or whatever. The other option is doing a PICSI. There are various options that we have to choose the best sperm when it comes to DNA being fragmented. The other advanced treatments, if we feel that the azoospermia is because of any hormonal reason or the count is less for any hormonal cause and it can be worked on by medication, it can be tried for a period of 2 to 3 months. That will again be the discussion that will happen with the andrologist. And then what are the chances, how do the hormones look like, what is the testicular volume, clinically what does it look like, and then we take a decision as to whether we should go for simple IVF preparation or whether we have to work more on the man. But then the other things is other options that we have for advanced ART treatment is vitrification. I think this is a very, very understated part of fertility, which a lot of people don't know, is just because someone is not in the state to have a child. As we all know, I think we've mentioned this many times before also, that the single most predictive factor of you having a success with ART is the age. So just because someone, I think having a child just because you are running out of age is absolutely a very wrong reason. So people should understand that in today's day and age, they have the option of freezing their gametes. If a woman is not married and she still wants to study some more, she wants to work some more, she wants to have a child later, she wants to probably finish her professional accomplish her professional goals, and just because she's 32 or 33 does not mean she has to jump into treatments and get a child. You can always freeze your eggs. You've not met the right person, you're not yet married, you probably want to, but you want to keep the option of having a child later in life. There are options of vitrification of oocytes. You can freeze your eggs and use them whenever you want to, even if when you are 45, 50. Obviously, I don't think it will take so long, but at least you will be mentally sorted, and you can freeze your eggs and you are sorted in the head that you have the possibility of having a child. And you meet someone and you get married, the next year you try, naturally it doesn't work out, you can always come back 5, 6, 7 years later and use those gametes. The other option is for the couple is married, but they don't want to have children yet, but they're running out of time. Freeze your embryos. Instead of when there is a single lady, we always give them the option of freezing oocytes, but when there is a couple, it's always better to freeze embryos rather than freezing the gametes individually, because the gametes as a unit, as an embryo, are stronger to the freezing and thawing process. They are more resistant to freezing and thawing when they are as a unit together as an embryo. So we should give them the option of embryo vitrification, and they can come back and have a child maybe 2, 3, 4 years later whenever they are ready. For azoospermic men, if they've had, obviously they will need treatments for their second child. So we always try and ensure that the IVF cycle that we do is good enough. And if everything goes on fine, touch wood, then they can freeze those extra embryos and come back maybe 2, 3 years later for their second child. This is all best case scenario. Doesn't happen with everybody, but then these are options that are available that people should be aware of, and think about it when they are probably just thinking of or probably very disheartened that they might never have their own genetic child, or it's too late for them. It's very important for people to know that they have these options of tissue cryopreservation in people who are going for cancer treatments is available. So be it a man who's going for chemotherapy, they can preserve their sperms. A prepubertal child going for chemo radiotherapy for any form of cancer can freeze tissue. Young girls can do ovarian tissue vitrification, can do oocyte vitrification. Again, that is a clinical decision that will be taken by us depending on what type of cancer it is, how urgent do they have to jump into the treatment, how much time do we have, what phase of the cycle they are in. So these are various options that are available in all our branches, and people should be aware that they have this option before they become very, very disheartened. Yeah, I think we are ready to take questions if we have any. Okay, Geeta is asking what is considered as advanced reproductive technology. Yeah, Geeta, I was just mentioning about this. So anything beyond ovulation induction and timed intercourse and IUI will come in the advanced ART treatment. So it includes IVF, ICSI, PGT, PGS, vitrification of embryos, vitrification of oocytes, tissue vitrification, ERA. All of this comes under advanced ART treatments. But just because we have them doesn't mean everybody has to go for them. It has to be decided with the clinician. Pinky is asking how long should we wait for basic ART? Pinky, it's a good question. I think everybody should be aware of this. A couple who's married for a year, staying together for a year, and आपने 1 साल तक try किया है to have a child और आप नहीं conceive कर पा रहे हैं for some reason, having intercourse at the fertile period, you have the knowledge of being in knowing the fertile period, and 1 साल से ज़्यादा हो गया, so you should come to the clinic and get yourself tested. But 1 year should be the time where you should try, unless there is a problem. जैसे कि अगर आपको पता है कि एक फीमेल को पीरियड्स नहीं आते रेगुलरली, पीसीओडी की प्रॉब्लम है, या मेल में इरेक्टाइल डिसफंक्शन की प्रॉब्लम है, या फॉर सम रीजन कभी टेस्ट हुआ और पता है कि ये ज़ूस्पर्मिया है, तो ऑब्वियसली आप 1 साल तक ट्राई नहीं करेंगे. बट अगर कोई नोन प्रॉब्लम नहीं है, तो यू प्लीज ट्राई फॉर 1 year and then come to the ART clinic if you are below 30. But if you're beyond 30, I think you should not try more than 6 months at home and come to the treatment center earlier. Vidya is asking how to improve endometrial thickness. Vidya, if you are asking about non-medical treatments, I don't have very good news for you. There aren't many options which are non-medical for this, but we have a lot of options that we have medically to improve the endometrial thickness. It can be increasing or titrating the dose of estrogen from 2 TDS to 1 TDS to 2 TDS to even 4 times a day, to even local form of estrogen. We have various other methods like a PRP installation, stem cell therapy, growth factors installation. All these are options that we have to improve the endometrial thickness. There are studies that say that acupuncture works to a certain extent, but it has not been validated as of now. But I mean, there is no harm in going for acupuncture, but along with medical treatments. But we don't have a lot of evidence on that. But then, as I said, there is no harm in doing that alongside medical treatments. But there are various ways of improving ET. Gautami, what are the success rates for basic ART? Yeah, Gautami, as I said, for IUI and ovulation induction and timed intercourse, the success rate varies from 15 to 20% with good ovulation in a good cycle where everything is fine, where the sperms that we've injected. यहाँ पे क्या होता है कि when we are doing a cycle, we see the sperm parameters after the partner has given it to us, and when we discharge you, we give you sperm parameters post-processing. So the post-processing sperm parameters kaise hai, how has your ovulation been like, how is your endometrium. We always ensure at Oasis that we don't do the basic ART treatment. We rather skip a cycle, because see, these treatments have a very limited success rate. As I said, if you do a good cycle with everything in place, the success rate is not going to go beyond 20. Because we can just ensure that the egg is ovulated and it is there waiting for the sperm, and we put the sperm. Beyond this, they're going, meeting, coming, fertilizing, implanting, all these things are not in our hands. So with everything going on well, the success rate is 15 to 20. But if we have an ounce of doubt that something is not wrong, the thickness is not good, we feel that the ovulation has not happened, or the follicle has not developed, or the sperm parameters are suboptimal, we should not do these treatments, because then it's very disheartening. We should ensure that we reach those parameters and then do it. And best case, it is not beyond 20%. So these simple treatments, we can try up to 6 cycles. So just because it's 20% in one, but what studies have shown us that after the 3rd, 4th cycle, the success rate decreases. That means there is a deeper problem. Most of the couples conceive in the first 3, 4 cycles of these basic ART treatments. What are the list of advanced ART treatments and what are the prescribed at what times? Lavanya, as I just mentioned, IVF, ICSI, TISA, pre-genetic testing, ERA, all these are advanced ART treatments. And there are different indications for all of them. We'll have to go through your history, your age, the previous treatments that you've had. If you've had IVF in the past, what has been the outcome, and then decide what all should be applicable for you. Because these are all expensive treatments. So just because we have all of them at our discretion doesn't mean we write and give this to everybody. It should help the patient to improve their chances. Only then it should be advised. Preeti is asking, how does ART treatment help with stress, and how long does ART take to be effective? Preeti, ART treatment doesn't help with stress. I would say stress affects the ART treatment. So one thing that we always ask the patients to do is that please leave behind all your stress once you come to the clinic on us, and don't go out with stress, because there are studies that have said that and validated that stress does affect the sperm and the egg quality. So inevitable sometimes, because we don't understand what the couple is going through. They have their own issues at home, with family, at work, where they struggle with infertility. But that is something that I feel that the patient can do to improve their chances. Not take much stress. Don't take any stress is a little difficult, but at least every time you get stress, you should probably divert your mind and not think about the treatment. Just, we always tell our patients, think about your treatments only when you come to the center. The minute you're out of this place, please don't think about what has happened here. It really helps. Abid is asking what hormones are given before IVF. Abid, there are different hormones that we have. Basically, the reason for giving hormones is that we have to try and increase the number of eggs. Or assuming that a woman will ovulate, she will produce one egg on her own. What can we do to improve her chances? We have to give her injections so that she produces more eggs. Something that I want to tell our patients is that we cannot create new eggs with IVF. We can only take out the eggs that are already there in the ovarian pool that a woman already has. So the injections that we give for this is follicular stimulating hormones, luteinizing hormones, human menopausal hormones. Sometimes adding growth hormone helps. Accentuates the actions of these hormones. So there are different hormones, and that what hormone should be given to you will be decided after seeing the profile. But most commonly we use FSH and HMG. Any evidence showing human eggs undergo stress in vitro? No, Syed. I mean, I think we just celebrated the 41st World IVF Day, and there has been enough evidence that there is no difference between in vitro and in vivo culture. Obviously, there are times, most of the times, if you have a good lab, if you have maintained good standards in your lab, if something is not surviving in the lab, everything going fine, obviously, there are chances where inevitable, that 0.2% of human error can be there. But most of the times, if you have good lab condition and good quality control over the lab, it doesn't matter. And technically, it gives us an idea if that the gamete is not, probably of that good quality that it can survive even in vivo. So, yeah, it all depends on the QC of the lab, I would say. Any other questions? Okay, so I think I hope you people had got some more information about ART treatments, basic and advanced. So the next time you meet your doctor, and when we give you options, and we always give the patient some time to decide. We leave the options in front of you. Tell you that in my opinion this is the best, but it is very, very important. And next time when you tell your doctor that, doctor, you decide, and when we say we can't, this is the reason we can't, because as I mentioned, these are not life-threatening diseases, and it is very, very, because how the patient is emotionally, financially, something we don't know. To increase, if a patient comes and they want to conceive immediately, the best option is IVF, because that is the quickest with the maximum success rate. But then that might not be affordable for all patients. Some patients might be a little apprehensive in going for IVF for the first time, and it's completely justified. It is completely justified to try simple ART treatments before jumping into advanced treatments. If you don't want to, if your profile allows you to, by that I mean we have age in hand and other things, other factors being in place, there's absolutely no harm in trying simpler ART treatments. We have a lot of couples who have conceived after simple ART treatments, who are not required to go to IVF. But when there is a deeper problem, we will have to do advanced treatments. It's something we cannot avoid. But that taboo should be removed from your minds, that ART treatments are harmful in any way for the husband or the wife or the child that is will be born out of ART. Please let us know if you have any other questions or topics that you want us to discuss in the next week, and we'll be back again next month with another topic. I hope you enjoyed the session. You can get back to us with any queries that you have that you haven't been able to ask now, or visit us at any one of our centers. Thank you.